Bismillahirrahmanirrahim. Quote of the day: the universe responds to specificity. Today, the topic of presentation is screening and diagnostic test, sensitivity, specificity, positive predictive value, negative predictive value. I am Dr. Bekbal, PGR Community Medicine, and I am presenting under the kind supervision of Professor Dr. Saira Afzal. Learning objectives of today's presentation is introduction to screening, types of screening, criteria for screening, sensitivity, specificity, negative predictive value, positive predictive value, recent advances, and MCQs. Learning outcomes. At the end of this presentation, participants would be able to describe screening, types of screening, sensitivity, specificity, positive predictive value, and negative predictive value. Introduction. Biggest challenge in preventive medicine is distinguish between people who have disease and the people who do not. Iceberg phenomena, the idea of the progress of the disease from its subclinical stage to overt disease. This is the visible part of the iceberg which show clinical illness, and this is the hidden part which shows subclinical cases, carrier, undiagnosed cases. The research for unrecognizable disease or defect by the mean of rapidly applied test, examination, or the other procedure in apparently healthy individual. Earlier, it is considered to conserve physician time for diagnosis, inexpensive lab tests, etc. But today, screening considered a form of secondary prevention. It detects disease in its earliest asymptomatic phase, whereas early treatment can be given and disease can be cured or its progression can be delayed. Now, difference between screening and the diagnostic test. Screening test done on apparently healthy individual, whereas diagnostic test done on sick or ill individual. It is applied on a group of individual, whereas diagnostic test is applied on a single patient. In screening, results are arbitrary and final, whereas in diagnostic test, diagnosis is not final. Screening is based on one criteria or cutoff point, whereas diagnostic test based on evaluation of signs and symptoms and lab findings. Screening test is less accurate and less expensive, whereas diagnostic tests are more accurate and more expensive. Screening test not a base for a treatment, whereas diagnostic test is a base for a treatment. Screening initiate comes from investigator, whereas in diagnostic initiatives come from patient. Now come to the uses of screening. Screening are used in case detection, prescriptive screening, which is defined as the presumptive identification of unrecognized disease which does not arise from a patient request. The people are screened primarily for their own benefit. For example, neonatal screening. Control of disease are prospective screening. People are examined for the benefit of others. For example, screening of immigrants for infectious diseases like Ebola, TB, syphilis to protect the home population. Screening for HIV and STDs, etc. Screening program may lead to early diagnosis, permit more effective treatment, and reduce the spread of infectious diseases and mortality. Number third is for research purpose to know the history of many chronic diseases like cancer, hypertension, etc. Screening may aid in obtaining more basic knowledge about the natural history of such disease. Initial screening provide a prevalence estimation. Subsequent screening provide an incidence. Number four, for educational opportunities, screening program help in acquisition of information of public health relevance, provide opportunities for creating public awareness, and for educating health professionals. What types of screening? Number one, mass screening, application of screening test to large unselected population. Everyone in the group is screened regardless of the probability of having disease or condition. Purpose, more efficient use of resources. For example, mammography for women over 40 years, hepatitis B screening for healthcare workers. Number second, selective high or high risk screening. Screening target at the individual at a high risk of developing a disease. For example, screening of a fetus for Down syndrome in a mother who already have the baby with Down syndrome. Screening for CA service in low socioeconomic status women. Screening for HIV in high risk groups. Number third type is multi-purpose screening. The screening of the population in which one or More than one test is done simultaneously to detect one or more disease. For example, screening of pregnant women for withdrawal, HIV, HPV by serological test. Number four type is multi-phase screening, the screening in which various diagnostic procedures are employed during the same screening program. For example, in diabetes, fasting blood sugar plus glucose tolerance test, and in sickle cell anemia, CBC and electrophoresis, HB electrophoresis. Number five, opportunistic screening. Screening offered during a healthcare visit for another reason. For example, checking blood pressure during a dental visit. Now, criteria for screening. Criteria for screening are set the principle used to determine whether a disease or a condition is suitable for population-based screening. These are originally proposed by Wilson and Wigner of the World Health Organization in 1968. The criteria based on two considerations: number one, disease, and number two, screening test. Disease. The condition should be important health problem. They should be recognizable latent or early symptomatic stage. The natural history of the condition should be well understood. There should be a suitable test or examination. They should be acceptable to the population. It should be acceptable treatment for patient with recognized disease. Facilitate for diagnosis and treatment should be available. There should be an agreed policy on whom to treat. The cost of the case finding should be economically balanced in relation to possible expenditure on medical care as a whole. Case finding should be continuing process and not once and for all project. Number second is screening. Screening should be inexpensive and easy to apply, simplicity, acceptable, valid, reliable, and yielding. Now we will discuss one by one. Simplicity. The test should be simple to perform, easy to interpret, and where possible, capable of use by paramedics and other personnel. For example, blood and urine test and ECG for early detection of hypertension. Number second, accountability. Since the participation in the screening is voluntary, the test must be acceptable to those who undergo it. In general, tests that are painful, discomforting, or embarrassing are not likely to be acceptable. For example, screening for prostate cancer might not be acceptable to the large proportion in the community. What is validity and reliability? Validity is the accuracy of the test, whereas the reliability is the precision of the test. Accuracy, how close is the result of the test to its true value? With precision, how close the result of a test on a repetition. In this figure, this shows low accuracy and low precision. This shows low accuracy and high precision. This shows high accuracy and low precision. And in this picture diagram, it shows high accuracy and high precision. Validity. Validity determines the accuracy of the test. It expresses the ability of a test to separate those who have the disease from those who do not. Components of validity: sensitivity, specificity, predictive accuracy. Sensitivity. The ability of a test to correctly identify those who have disease, that is true positive. The proportion of a truly ill population. Sensitivity is true positive divided by true positive plus false negative, that is the total. This is the formula: sensitivity is equal to true positive and divided by true positive plus false negative. Be sensitive to those who have disease. Sensitivity is equal to screening. Specificity. The ability of a test to correctly identify those who have the disease. That is true negative. Proportion of truly healthy population. Specificity is true negative. True negative is divided by true negative plus false positive. Specificity is equal to true negative divided by total of true negative and false positive. Negative people get specific. Specificity is equal to confirmation. This is a calculation. Sensitivity is equal to true positive, that is 80, divided by total, that is 100, which is equal to 80%, and specificity is equal to true negative, that is 800, divided by total, that is 900, and is equal to 89%. An ideal screening test should have 100% sensitivity and 100% specificity, but that is not practically possible. False negative. If a person with a disease is labeled negative, it shows false reassurance, ignore any disease sign and symptom, postponement of treatment determinal to overall health. It has low sensitivity and high specificity. False positive. If a person without a disease labeled as a positive, further testing will be long, expensive tests, discomfort, inconvenience, and anxiety, burden on health facilities, emotional trauma, difficulty in delabeling the patient. It has high sensitivity and high specificity. Now, bimodal and unimodal distribution. This is the bimodal distribution which show two distant peaks, that is positive and negative. They indicate that data might come from two different groups or population. This is the unimodal distribution which show clear one peak. It means that most data value cluster around a single central value. What is the concept of cutoff point? Unlike in bimodal distribution, dichotomous, some diseases come in continuous variables, for example, diabetes and hypertension. In this case, it is very difficult to calculate sensitivity and specificity. So a cutoff point must be set to distinguish between negative and positive and negative result. Consider 20 diabetics and 20 non-diabetic used for screening a blood sugar test from low to high. Low cutoff value, this shows sensitivity 85 and specificity 20. False positive originate, more non-diabetic are diagnosed positively. Whereas in high cutoff point, sensitivity is 25. This is the high cutoff point, sensitivity is 25 and specificity is 90. False negative originate, more diabetic are non-diagnosed positively. So different cutoff point yield different sensitivity and specificity. The cutoff point that identifies more true negative will also identify more false negative. The cutoff point that identifies more true positive will also identify more false positive. The choice of a high or a low cutoff value for screening therefore depend on importance we attach to false positive and false negative. In case of lethal disease, early intervention possible, cutoff point must be set at low level as greater sensitivity is required. False positive can be tolerated. Predictive accuracy. Positive predictive value, negative predictive value. Positive predictive value, the proportion of a people who is screened positive that is actually have disease. Are the people with disease correctly identified? Negative predictive value, the proportion of people who is screened negative are actually free of disease. Are the people without disease correctly identified? Now, this is the calculation of positive predictive value and the negative predictive value. Positive predictive value is equal to true positive divided by true positive plus false positive. That is the total 180 is equal to 44%, and negative predictive value is equal to true negative divided by total 800 plus 20, that is 820 is equal to 98%. Predictive accuracy depends on prevalence of the disease and specificity of the test. More prevalent disease has high predictive value. That's why screening is more efficient and productive if done high risk population. Increase in sensitivity cause modest increase in positive predictive value, but increase in specificity raise positive predictive value markedly. Reliability. Reliability determines the precision of test. It means that all the result of the test should be similar when conducted each and every time. This is not possible because of the variation that cause the test to not yield same result every time. Three types of variations: intra-objective variation, intra-observer variation, and inter-observer variation. Yield. Yield is the amount of previously unrecognizable disease that is detected and brought to treatment as a result of screening. Yield is equal to true positive plus false positive divided by true positive plus false positive plus true negative plus false negative. It depends upon prevalence of the disease and sensitivity of screening test, participation in program. Hence, yield is of screening test is high in high risk screening. Now, the conclusion. Screening, despite its flaws, it is a major public health determinant measured by its effect on mortality, morbidity, and disability. Establishing appropriate criteria required considerable knowledge of the natural history of the disease, adequate facilities for follow-up and prescription. It is necessary to ensure that program is continuously monitored to confirm the effectiveness is benefit maintained. Benefit is greater than cost. Newer fields such as genetic screening are on the rise, which would help the case. Now come to the recent advances. Evaluation of community-based screening tools for early screening of osteoporosis in post-menopausal Vietnam women. It is an article published in 2022. Background: osteoporosis affects people worldwide. However, there are few validated tools for the early screening of osteoporosis in Vietnam. We set out to evaluate the performance of osteoporosis self-assessment tool for Asia and osteoporosis screening tool for Chinese for early screening of osteoporosis in most menopausal Vietnam women. The result of the osteoporosis determined BMD varied between the anatomical site, the range from 43.4% to 54.7% in the lumbar vertebra and 29.2 to 8.9 in the left right neck, respectively. For the vertebra, the area under curve for OSTA range from 70.9 to 73.9 and for OSTCs range from 68.7 to 71.6. The predictive value of the both tool are higher for femoral neck with the AUC of the OSTA for the left and right femoral neck being 80.0 and 85.8 respectively. The high sensitivity and specificity of the OSTA were 74.6% and 81.4%, while these figures for OSTCs were 73.9 and 82.6 respectively. Assessing the value of screening tool, reviewing the challenge and opportunities of cost effectiveness analysis. Screening is an important part of preventive medicine. Ideally, screening tool identify patient early enough to provide treatment and avoid reduced symptoms and other consequences, improving health outcome of the population at a reasonable cost. Cost-effective analysis combine the expected benefit and cost intervention and can be used to assess the value of screening. Objective of the review seek to evaluate the latest cost-effectiveness analysis on the screening tool to identify the current challenges encountered and potential method to overcome them. The conclusion that to capture all the important cost and outcome of the screening tool, screening pathway should be modeling include patient treatment, also false positive and false negative patients are likely to have important costs and consequences should be included in the analysis as the patient are difficult to identify in a regular data source. Common treatment patterns should be used to determine how the patient are likely to be treated. It is important that assumption that clearly indicate that the consequences of the assumption are tested in sensitivity analysis and particularly independence of the test level of the patient and provide compliance and guideline. As the data is rarely available, including the progression of the undiagnosed patient, extrapolation for diagnosed patient and may be necessary. Now come to the MCQs. MCQs number 1, a community health worker is planning a screening camp for hypertension. Using a digital sphygmomanometer, what principle should be ensured to maximize the detection in early stage? A, high specificity of the test. B, multiphasic screening protocols. C, high sensitivity to catch early case. D. Low cost of equipment. E. Use of complex diagnostic information.
A.
C. High sensitivity.
C is the right option. High sensitivity to catch early cases. MCQs number second. In which situation would you prefer a test with high specificity over sensitivity? Cancer, diagnosing cancer early. B. Mass screening for TB. C. Screening in a high risk population. D. Initial assessment in the community. E. Confirmatory test to avoid false positive.
E option.
Yes, E is the right option. MCQs number three. A test for dengue fever is high in a high prevalence area. Show a large proportion of true positive among those who test positive. What value is being demonstrated? A. Sensitivity. B. Specificity. C. Positive predictive value. D. Negative predictive value. E. Reliability. C is the right option. Positive predictive value. MCQ number four. Result of screening test for diabetes compared to confirmatory test OGTT. The specificity of the test is A 96.1%, B 86.1%, C 76.1%, D 56.1%, E 66.1%. Specificity formula of specificity is true negative divided by total. This is the solution. 500, that is true negative divided by total 520 is equal to 96.1. So the answer is A. MCQ number 5. Hospital use a highly sensitive test for initial screening and highly specific test for confirmation. What is the advantage of this approach? A. Reduce cost. B. Increase false negative. C. Maximize detection and minimize the false positive. D. Avoid confirmatory test. E. Improve compliance.
C.
C.
Yes, C is the right option. MCQ number 6. Result of screening test for hypertension in ABC community. The sensitivity of the test is A 23.3%, B 33.3%, C 43.3%, D 53.3%, E 63.3%.
B.
B.
Yes, B is the right option. Sensitivity is equal to true positive divided by the total. So it is 33.3% and B is the right option. MCQ number 7. Result of test for breast cancer in ABC community. The negative predictive value of test is 37.1%, B 47.1%, C 57.1%, D 67.1%, E 77.1%. This is the formula. Negative predictive value is equal to true negative divided by total. So the answer is C, 57.1%. This is the solution. 200 divided by 350 is equal to 57.1%. MCQ number 8. A test detects disease accurately among those who have it. What property does this define? A. Specificity. B. Predictive value. C. Sensitivity. D. Reliability. E. Yield.
C.
Reliability.
C is the right option. MCQ number 9. In a multi-phasic screening setup, which of the following best describe its advantage? A. Screening for multiple conditions using different tests simultaneously. B. Applied only high-risk individual. C. Focus on detecting a single disease. D. Always use invasive technology. E. Does not require follow-up.
A.
Yes, A is the right option. Screen for multiple conditions using different tests simultaneously. MCQ number 10. A new test for tuberculosis showed consistent result across multiple observers but failed to detect all the disease individual. What does this suggest? A test has a high validity. B, a test is a high sensitive. C, a test has a poor specificity. D, the test is reliable but not sensitive. E, the test has low yield.
Delta.
Yes, D is the right option. This is answer key. This is the YouTube channel where this video will be uploaded. And thank you.